morning, everyone. Thank you for being invited in this very important meeting. And I'm very sorry that I won't be available, in a live presentation. But thank the organizers for providing the opportunity to do it this way. So the topic that I was given gave me a hard time, I have to tell you. Does an association exist between congenital heart disease and malignancies? Okay, I'm a pediatric hematologist-oncologist, so I may have to find some answers to this question. There's no conflict of interest in my presentation, and the issues that we are going to discuss are congenital heart disease and aging diseases, studies registry-based and population-based, congenital heart disease in genetic predisposition syndromes and what type of cancers, if any, occur, incidence of cancer compared to healthy controls, what type of cancer do they get children with congenital heart disease and non-genetic predisposition. A few more words on neuroblastoma and cancer in Down syndrome, and then the two major fields of radiation exposure and role of thymectomy. Patients with congenital heart disease, you know more than I do, present in 9 out of 1,000 births. And those children have shown increased risk for aging diseases as atherosclerosis, which is quite high, 10 to 100 times more frequent, but even to cancer, roughly 2 times more common. Here I have put 5 studies starting 2014 and up to the most recent 2022 that I found. There were many interesting studies, but I found those very interesting. And it is also interesting that the majority come from Sweden and one from Denmark, and there is one from Taiwan. So the one from no extra risk if Down and Fanconi are excluded. People in Taiwan, they found increased risk of leukemia, lymphoma, CNS tumors, and head and neck tumors. And then the 3 following studies, for us being Greeks, I find it very interesting that the first authors are Greeks. The one by Mantalanakis showed increased risk by age 41. 1 out of 50 have developed cancer. But I'm going to talk about children developing cancer today. The other, by Karazisi, 23% increased risk of cancer, and especially of leukemias and lymphomas, if we are talking about children from birth to age 17. And the other Greek author, Kambitsi, has shown also in Swedish study, increased risk of lymphoma and hepatoblastoma. Let us see those in more details. In this graph, we can see patients without congenital heart disease and how cancer goes up as those children grow to adults. And those are with congenital heart disease and how higher is the curve of cancer in this. Also, what I already have mentioned, these are the healthy controls, and those are patients that they were born with congenital heart disease. And you can see that depending on the years study, as we go closer to our days, we do see more cancer in these children compared to healthy controls, of course. Okay, so I already mentioned increased risk of lymphoma. More risk of lymphoma in the complex congenital heart diseases, increased risk of hepatoblastoma, and in Down syndrome of acute myelogenous leukemia. So, patients with congenital heart disease have cancer risk higher, especially if the individuals bury cancer predisposition syndrome. We'll see those a little later. In all children with congenital heart disease, including cancer predisposition and transplanted, the risk is increased by 23%. It's 18% if we subtract congenital cancer predisposition syndrome and transplanted patients. I mentioned already that it is higher in ages 0 to 17, and those born between 1990 and 2017, they had double risk of developing cancer. If surgery for congenital heart disease was done at the first year of life, then the risk is double. And additional factors, radiation exposure, thymectomy. Skin cancer in all ages compared to adults, to controls, and hematologic malignancies in the youngs. Do we know why those children get congenital heart disease? In the majority, we don't know. But there is a percentage of 10 to 20% in whom there are genetic predisposition syndromes, and those can also develop cancer. Okay, let us see in this very busy slide, but I will go in a way that you will be able to understand. We have the very common trisomy 21 Down syndrome. You as pediatricians and pediatric surgeons know better than I do the type of congenital heart disease they get, how frequent it is, and what do those children get? Sorry, I go back. They get leukemia, gonadal tumor, germ cell tumors. Children with Edwards syndrome, they get hepatoblastoma and Wilms. Children with Patot syndrome, trisomy 13, they get embryonal tumors, leukemias, germ cell tumors, and other benign tumors. And children with Turner syndrome, they get CNS tumors, gonadoblastomas, and bladder carcinoma in older ages. Now, children with DiGeorge syndrome, or as today is called 22q11.2 syndrome, is much easier, DiGeorge syndrome, I understand. They get autoimmune thrombopenias, neutropenias, and in general cytopenias, atypical teratoid rhabdoid tumor, leukemias, lymphomas, neuroblastoma, hepatoblastoma, osteosarcoma, thyroid cancer, Wilms tumor. Children with Noonan syndrome, they have the gene PTPN11. So those children get pulmonary stenosis, and the most common type of cancer is juvenile myelomonocytic leukemia, rhabdomyosarcoma, a very rare leukemia indeed, and neuroblastoma. In the same group of Noonan syndrome, we can incorporate the rasopathies as Costello, Leopard, and the cardiovascular cutaneous syndromes. They get the same type of tumors, those. Williams syndrome is the only one that can give rise to Burkitt lymphoma, Ewing, and also to ALL. And I left at the end the two very well-known cancer predisposition syndromes, the one of tuberous sclerosis. Those children get heart rhabdomyomas, but also they may get renal tumors, brain tumors, neuroendocrine tumors of the pancreas, very rare, but we do see that. And syndrome with Gorlin, in which other PITCH1 or SUFU genes are involved, they may get heart fibroma, and those children, they have to be screened regularly for medulloblastoma. Okay, let's move to Down syndrome with congenital heart disease and cancer. And the majority is trisomy 21. Now, children with Down syndrome, they get, and this is something that we learn from our early pediatric training, they get more commonly leukemia. In the majority, Down syndrome is due to trisomy 21. One entity that is given two names, TAM or TMD, and this stands for transient abnormal myelopoiesis or transient myeloproliferative disease. It may be seen in 10% of children with Down at birth, and it is scary. if you see the peripheral blood, because they get higher white blood cell count, you get scared. But this may resolve at 3 months. However, a fifth of them develops acute myelogenous leukemia before the age of 5. In general, Down syndrome bury the GATA1 gene, and they get 150 times more frequently acute myelogenous leukemia. And it is very interesting that AMLs are bad diseases for children, as they are in adults. But in Down syndrome and AML, the survival is better because myeloblasts are very sensitive. I mean, one of the reasons is that myeloblasts are very sensitive to cytosine arabinoside, one of the drugs that we use. Out of these AMLs, the most common is acute megakaryoblast leukemia, and this is the slide, which they get 500 times, more frequently. On the other hand, ALL is more common than the general population, but it is less common than AML. The survival here is worse because those children have a lot of toxicity to one very important drug, methotrexate, and they get serious infections from which sometimes they die. In this cartoon, we can see what happens with TAM and AML in Downs. In the embryonal liver, we have this trisomy 21 chromosome, and those are the progenitors, which as the embryo grows, they may get this GATA1 gene, and they may develop the TAM, the abnormal myelopoiesis. If those cells do not die and they continue in thriving, then they become blasts, and we have in the bone marrow the acute myelogenous leukemia. Things are a little different in acute lymphoblastic leukemia. They are in this chromosome 21 various other genes that they may promote and make the B cell proliferate, upregulate. They get this gene, CRLF2, or the JAK genes, and they develop acute B cell type lymphocytic leukemia, non-TALL usually. So in this slide, I have put the Down syndrome and ALL, Down syndrome and AML, children who 50% of those have already some congenital heart disease, as you know. And they have those JAK mutations, but the cure rate is very low for ALL. On the other hand, Down syndrome and AML, in the majority are M7, megakaryoblast leukemia. They have the GATA1 mutation, and the cure rate is very, very high, unbelievably high. See this again, the 65%, and let me show you what therapy in acute lymphoblastic leukemia means in our days. And this is from the Greek patients. This is the ALIC protocol that all patients in Greek follow, and we have an overall survival at 5 years, 91%, compared to 65% in Down syndrome. So worse lymphoblastic leukemia, much better myeloblastic leukemia in Down syndrome. This extra chromosome 21 is a very, very peculiar chromosome. It's the smallest human chromosome. Contains 738 genes, of which 233 are coding genes. And just take a look at these 4 that play an important role in what? In why people with Down syndrome get leukemia, but the majority are protected from developing solid tumors. And there are various reasons. They are mentioning 10 reasons. I'm going to go really fast on this. Neural development. They have, children with Down have fewer neurons and smaller. That's why they don't get medulloblastoma. But they have normal glial cells, so they equally get gliomas. They have a gene which inhibits neuroblastoma lines, no neuroblastoma. They have tumor suppressor genes, but they get leukemias as M7 I mentioned earlier. Disturb metabolism, increase apoptosis, impair angiogenesis. What I find very interesting is that there's a protective effect in Down syndrome of tumor stroma. That's why adults with Down syndrome, women, do not get breast cancer, which is a tumor stromal rich. On the other hand, germ cell tumors, leukemias, and retinoblastomas are stromal pure, so they do get those type of tumors and leukemia. Impair immunity, they are epigenetic changes, they are non-genetic factors, less exposure to known carcinogens. Why? Because those children are very overprotected. They have less sexual activity, they don't get job, they don't go out, okay? And there are also some factors outside chromosome 21. In this cartoon, you can see all these, the neurodevelopment, tumor suppression gene, metabolism, apoptosis, angiogenesis, tumor stroma, immunity, epigenetics, and so on. So, as a summary, they do get leukemias, they don't get so many solid tumors. You can see that even more clearly. If they get something besides leukemia, they get testicular tumors, slightly increased retinoblastoma, germ cell tumors, bulb tumors, decreased thyroid and CNS tumors, very much decreased the very common pediatric tumors, neuroblastoma, Wilms tumor, medulloblastoma, and also very low breast, I mentioned that, prostate cancer and bowel cancer in older individuals. And it is controversial whether they get or not lymphomas. Now, I had put separately neuroblastoma because some of the congenital heart diseases come from the neural crest. They are anomalies derived from a neural crest, 30%. And in this paper, 19 out of 21 of those coming out from the neural crest develop neuroblastoma. In our clinic, in 8 years, we had 12 infants with neuroblastoma. One of them, only 1 out of 12, had been operated for transposition of great arteries, and soon after, his chest X-ray showed a posterior mediastinal neuroblastoma. He's fine. Now, I mentioned irradiation and thymectomy. Irradiation. How does irradiation act? If we keep in our mind the two-hit hypothesis by Alfred Knudson, it seems that the first hit in order for a cancer to be developed is the congenital heart disease. Then we may consider as a second hit the radiation exposure. In this table, which I find very important, you can see the equivalent of chest X-rays and the procedures that few people, the cardiosurgeons, do in our babies. So ablation procedure goes up to 760 chest X-rays. Patent ductus occlusion, 360. Balloon, valvuloplasty, 410. So see the reasons why those children may get more cancer. So procedures to be blamed are diagnostic catheterization, interventional catheterization, computed tomographies. No one says not to do those. Just keep this in mind. Patients with congenital heart disease at 15 up to 20 years of age have cumulative exposure equivalent to 1,000 up to 2,000 chest X-rays. And children are more vulnerable than adults, 3 to 4 times. Because why? Because we expect them to live longer, right? And also they have increased number of dividing cells. And I'm taking the opportunity to show this. No adult tumor grows as rapidly as a normally divided embryo. One study named Coccinelle from 2000 to 2013 has studied 17,000 children below age 14 that had undergone cardiac catheterization. Those children had significant, not statistically significant, increase in leukemia, lymphoma, and some solid tumors, as thyroid. How radiation acts? It may induce chromosomal alteration. It's my face here, but I have the chromosomal alteration down there. telomere shortening, as here, which increases the instability and promotes cancer. And also, the irradiation that those children get during cardiac catheterization increases, it was shown, and I have the papers here, double-strand breaks in the peripheral blood, very difficult to repair, and this instability can promote cancer. So, if you go back to Alfred Knudsen's hypothesis, the two-hit hypothesis, we have a genetic syndrome, germline and gene mutations here, and children get congenital heart disease. And then we have a second hit, radiation exposure, other factors also, and we have the congenital heart disease plus cancer. So genetics load the gun, radiation pulls the trigger. How about thymectomy? It depends. I found out by reading, about this presentation that in the majority you have to do thymectomy in order to reach, the place, the region that you have to reach as surgeon. The age of thymectomy, if it is partial or complete, how much time has elapsed from the time of thymectomy, and the sequelae. We may see alteration of this pool, CD4, CD8, CD memory, CD naive, acceleration of getting old, those cells, immunosenescence, decline of cellular immunity, increased risk of cancer. In particular, after transplant, children get impaired EBV and CMV response, dysregulation of T cells, and the risk of EBV-related lymphoma post-transplant or lymphoproliferative disease goes up to 15%. Is this immunity recovering, and when? I think it mimics the George syndrome, which is not really recovering very much. And those issues that I mentioned are shown in these papers, alteration of T-cell pool. Some others say normalization of T-cell pool after 5 years. So, what do we get as taken as a model the DiGeorge syndrome? With decreased CD4, decreased CD8, decreased naive T, and alteration of CD4 to CD8 ratio. Infections, autoimmunity, and malignancies. OS, ALL, neuroblastoma, lymphoma, hepatoblastoma, Wilms, and thyroid cancer. It is important to spare thymic tissue during thymectomy if one can do that. So, in order to conclude, children with congenital heart disease have higher incidence of cancer compared to healthy controls, even higher if born between 1990 and 2017. It's a higher risk for leukemias, lymphomas, ages 0 to 17. 10 to 20% of children with genetic predisposition syndrome have congenital heart disease, and the risk is higher if they get this GPS and if they are transplanted to 23. Hepatoblastoma, non-Hodgkin lymphoma, AML in Down are the most common. Radiation exposure at 15 to 20 years is equivalent to almost up to 2,000 chest X-rays. Higher incidence of cancer if thymectomy is done, and I mentioned the reasons why. Congenital heart disease in Down is 40 to 50%, so those children get the additional issues of the chromosome 21, the triple chromosome 21. The risk of cancer in Down syndrome, they do get the abnormal myelopoiesis, the AML, more frequently acute myelokardioblastic leukemia, less frequently leukemia lymphoblastic. Decreased risk for CNS, neuroblastoma, and Wilms, the very common pediatric type of cancers. So if we like to think of the main risks are cancer predisposition syndrome, radiation exposure, and thymectomy. Can we do something about that? We have to know about that knowledge. We have to be able to early detect the problem, to treat these children very cautiously for 2 reasons. Because children, the very small kids, they are very vulnerable to chemotherapeutic agents and, of course, to radiation, which we will avoid as much as we can. Can we prevent that? I leave this up to you. Thank you very much for your attention.